Assalamu alaikum. Now we will start our talking with tackling pivotal health concerns. Allow me to welcome our moderator, Dr. Anwar Bouhamra, Dr. Anwar Al-Saigh, Dr. Ibtihal Mohamed. Dr. Anwar, the talk is for you.
We want to welcome Dr. Hamid Bastaki, the head of the Communicable Disease Controlling Division at Ministry of Health in Kuwait, PhD in Epidemiology and Public Health from University College London. He will talk today about the strategy of HPV vaccine introduction in Kuwait. Welcome, Doctor.
Thank you very much. Good morning, everyone. Today, my session will involve looking at the strategy for HPV vaccine introduction in Kuwait. Just as an overview for HPV, the human papillomavirus is a virus that spreads from person to person through skin-to-skin contact, and it's one of the most common sexually transmissible infections. The HPV is vaccine preventable, and there's over 100 known strains. Over 40 of them affect the oral and the genital areas. Most HPV infections are asymptomatic, and they resolve without treatment. Most men and women who have ever been sexually active will acquire the infection at some point in their time. In some individuals, this HPV infection would persist, and this persistent infection is what usually results in an increased risk of cancers. This usually affects 5% of the individuals who are exposed to HPV infection. If we look at the estimates of HPV prevalence globally in males and in females, so if we look on the left, we could see that for females, the peak prevalence is at ages 20 to 24, and then it starts to decline. In males, it peaks at 25 to 29, but it remains elevated throughout lifetime. If we look at estimated annual global number of cases of HPV-related cancers, we could see that cervical cancer does represent the bulk of the burden, but that there's also HPV-related cancers which could occur in males at the same time. One interesting finding in countries that have introduced the HPV vaccine, so the HPV vaccine has been available for the last 15 years. In the United States, it's been used and the uptake is quite high for the HPV vaccine. But when it was first introduced, it was introduced for females only. It was a female-only vaccination. This had resulted in a decline in the number of cervical cancer cases in females. But what we could see is there's an increase in incidence on HPV-related oropharyngeal cancer in males. It increased, and recently it exceeded the incidence of cervical cancer in females. This highlights the impact of the vaccination. This resulted in the majority of the countries switching from female-only vaccination to vaccinating both males and females. So it is very effective at preventing HPV-related cervical cancer, but why stop there? Why not cover other HPV-related cancers, including oropharyngeal cancer? The other question is, we need to look at local data from Kuwait. Yes, HPV is prevalent in a lot of different countries, but is there a need to introduce the HPV vaccine in Kuwait? If we look at the incidence of cervical cancer, the cervical cancer incidence is quite low. It's 3.2 per 100,000. The WHO recommendation target for eliminating HPV and cervical cancer is a cervical cancer incidence rate of 4 per 100,000. So we already meet that target. Why is there a need for the vaccination? One thing to keep in mind is that with HPV infection, it takes approximately 15 years for the cancer to develop. So the cervical cancer incidence today reflects HPV prevalence before 15 years. So what we actually need to look at is other indicators, not cancer, which takes a long time to develop. Other indicators which can be used is the incidence of genital warts. So from HPV infection to genital warts, it's a few months. It takes a few months. The incidence of genital warts is 167.8 per 100,000. This is comparable to other countries where the incidence of cervical cancer is high. So this indicates that there is a current need for HPV vaccination. Why wait 15 years' time when the incidence of cervical cancer and other HPV-related cancers are high, if we could take action now and vaccinate the individuals. Another indicator to use is to look at HPV prevalence in Kuwait. So in antenatal clinics, these are asymptomatic women, it's the general population. We looked at HPV prevalence during antenatal screening. So these are not symptomatic, they're not symptomatic, they should reflect the general population. The only risk factor they have is that they are sexually active. For those individuals who are screened, the prevalence of HPV ranged between 10 to close to 23%. This percentage is also comparable to other countries where the incidence of cervical cancer is higher, and it also reflects the HPV prevalence in those countries. So this is another factor that the time to introduce the HPV vaccine is now. There's 158 countries in total that have HPV vaccination programs. 69 countries have gender-neutral vaccination, so they vaccinate both males and females. In the Gulf, Bahrain, Qatar, and the UAE all expanded their programs to make them gender-neutral. Saudi Arabia still has female-only vaccination. The UAE was the first country to launch their HPV vaccine in 2008. They started off initially as female-only, and now they've expanded to gender-neutral vaccination. The vaccine available in Kuwait is the 9-valent vaccine. The previous vaccine which was developed is the quadrivalent, the 4-valent vaccine. The 9-valent vaccine covers the types which cause the most disease, as can be shown in the next slide. So the one in these graphs, they look at the portion in blue, looks at the level of protection covered by the 4-valent vaccine, and the one in pink looks at the level of protection, additional protection, when adding the 9-valent vaccine. So the overall levels of protection can be seen in green at the top. Because the vaccine has been available for more than 15 years, there's an abundance of evidence available, so it's not a new vaccine. There's real-world evidence related to safety and efficacy, so we're not only using data from clinical trials. All of these countries we could see on the right-hand side, there's decades worth of data from Sweden and the USA because they implemented it very early, and there's additional studies from all of these other regions. If we look at the safety profile, on the left we could see more than 29,000 people were included in the clinical trials for the quadrivalent vaccine. More than 15,000 individuals were included in the clinical trials for the 9-valent vaccine. And the most common adverse events were injection site reactions and headache. Most of the adverse events were mild and moderate. And then since the vaccine was registered and licensed, the real-world evidence showed that there was a similar profile to the clinical trials in terms of adverse events. In terms of real-world effectiveness data, if we look at the bars in the middle in terms of reduction in cervical cancer, this was a longitudinal study. So they followed up individuals who received the vaccine 15 years ago to look at the effectiveness of the vaccine in the real world. There was an 87% reduction in cervical cancer amongst those who were vaccinated compared to those who were not vaccinated in those aged 12 to 13 years. This reduced to 62% in those aged 14 to 16 years, and then it reduced to 34% in those aged 16 to 18 years. This highlights the importance of early vaccination. The earlier you vaccinate, the more protection you would get. If we look at the right, in terms of genital warts, there was a study in Australia which looked at genital wart incidence in both males and females. And then after introducing the gender-neutral vaccination program in Australia, there was a reduction in genital warts both in males and females. On the left, we could see that similar evidence was published related to data from the United States. The biggest barrier, I think, in Kuwait isn't related to the evidence, because the evidence is there, and we do have clinical trials, we have real-world evidence in terms of the safety. It's a very effective vaccine. The main barrier we have in Kuwait relates to awareness and the knowledge related to how important the vaccine is. So in February 2023, we conducted a study looking at the knowledge, attitudes, and acceptance of the HPV vaccine amongst the general public. Only 18% of the study participants, so there was a total of 678 individuals who participated, only 18% of the participants displayed good knowledge. And by good knowledge, the definition was having a passing score of over 50%. So even though they do have good knowledge, it isn't that they have a lot of awareness or knowledge related to HPV infection. It's just that 18% reached a passing score. But at the same time, 82% had positive attitudes. So should you provide them with the correct information, the individuals would be likely to receive the vaccine. But at the point of the questionnaire, at the point of the survey, only 49% would accept the HPV vaccine for themselves, and only 38% were willing to vaccinate their children if offered by their treating physician. So this leads us to the HPV vaccination campaign in Kuwait. The main thing we wanted to focus on was increasing awareness. We divided it into different phases. There's a lot of misconception. So first is increasing general awareness related to HPV infection, increasing awareness related to HPV vaccine. And in terms of consideration, we looked at countering myths. A lot of people think it's a female-only vaccine. A lot of people think that the HPV prevalence is low. So it's countering the information which are prevalent amongst the public. The key points of the media campaign, it's to focus on cancer prevention. It is a very effective vaccine which can prevent cancer. So instead of talking about sexual transmission and it being a sexually transmitted disease, focus on the key factor of it being cancer prevention. The second is to increase awareness of HPV infection, and it's associated with all HPV-related cancers. Don't specifically focus on cervical cancer. Focus on all HPV-related cancers. Highlight the eligibility of males in vaccination. Historically, partly it's the fault of healthcare, because the messages were mainly targeted towards cervical cancer. But now we know that it's all HPV-related cancers which could be affected. So we decided to focus on including males in the media campaign. And the last point is, in Kuwait, it's been approved for 9 to 45 years, but we do know that it's most effective when given early. So the messages we send is to focus on the importance of early vaccination. So currently we're in phase 1. The vaccine has been launched in 35 clinics spread across Kuwait. It's the 9-valent vaccine which is available. And for phase 1, the main aim of the first phase is to increase awareness. The target group is boys and girls aged 11 to 12 years old, and the awareness would focus on school-based messaging. The eligible group is 9 to 45 years. This is a very wide age range compared to other countries. Other countries have a limit of up to 26 years, but the vaccination committee reviewed the data in Kuwait. The date of sexual maturity might be a bit later in Kuwait compared to other regions. That's why the age range is wider. And in terms of the second phase, The main goal of the second phase is to increase coverage, because as we said, the first phase, it's to increase awareness. Once the level of knowledge within the community increases, then the second phase, it would be to introduce it as part of the routine vaccination, because it is a very effective vaccine. The target group would be boys and girls aged 11 to 12 years, while maintaining community-based services for those aged between 9 to 45 who do not receive the vaccine at schools. In terms of the logistics, the vaccine is available in more than 35 vaccination clinics. It's walk-in without an appointment. There's clinics which are open both in morning and the afternoon sessions. And the vaccine has already been added to the Kuwait electronic immunization system and adverse events reporting platform. In terms of the communication platform, the media strategy focused on 3 cohorts. For those who are less than 18, the focus is towards tailoring the message towards the parents. And we had, for the adults, we divided them into 2 groups, and we adjusted the messaging for younger adults and for older adults. We also sent messages to the hotline in Kuwait, 151, to respond to queries from the public. And then the doctors in the hotline were also instructed that if they were provided with messages related to HPV and the vaccination, and if there are questions which come up which we didn't cover in the Q&A session which was provided to them, they would send it back to us so we could review the evidence and provide a structured response. So there won't be multiple messages being given towards the public. If the questions are beyond the scope of what can be answered by 151, they're instructed to go to their nearest preventative medicine clinic and talk to the preventative medicine physician to respond to their queries. Next, I'll just present a few examples of the initial media campaign. The logo for the campaign is "Protect yourself and those you love, لحماية نفسك ومن تحب." We've used multiple media platforms for spreading the message. There's vaccination center branding, messages on Instagram. There's clinic and hospital-based branding, and we've also included posts on X, which is formerly Twitter. These are examples of the messages we have put through the MOH channels, and an example of the branding which is present at the clinics. This is just highlighting that the vaccine has been added on the electronic platform, and all vaccines administered will be registered on the electronic system. The main focus, though, isn't the media awareness messages. The main impact comes from healthcare workers. Healthcare workers are the biggest driver towards an individual accepting the vaccine. So we focused on healthcare workers. We organized multiple workshops, including where each hospital was required to nominate physicians from each specialty. So it's not individuals who are interested in hearing about HPV. It's healthcare workers which were nominated from their specialty to attend, so they could, if they did have tough questions related to HPV, they could ask it then and there. And if there are misconceptions, they could address it, because we need to have solid evidence as a healthcare workforce in order to convey the correct message towards the public. If the hesitancy comes from the healthcare worker, it would be exacerbated 10 times at the point of the individual receiving the vaccine. And this is corroborated by evidence. So if we look at data from a meta-analysis and a systematic review between 2007 and 2015, and individuals had 10 times higher odds of initiating HPV vaccination if they had a healthcare worker which recommended the vaccine, and they were 5 times more likely of completing the vaccination series if they were recommended the vaccine by the healthcare worker. But at the same time, only about a third of the parents reported receiving a high-quality recommendation from their healthcare provider. So it's up to us to convey that message to the general public at the time of the consultation. And this also corroborates the evidence. Based on the data from the United States, adults aged 18 years to 45 years of age were 11 times more likely to get vaccinated if they received a provider recommendation compared with adults who did not receive their recommendation. Finally, just for an HPV vaccination campaign to be successful, there's a lot of evidence. As we mentioned earlier, 159 countries have already rolled out the vaccination campaign. If anything, we are late. But it's good to start now, and it's good to raise awareness. But from the experiences of the different countries, including the experiences of the Gulf, we could see that multifaceted strategies should be used for the campaign to be successful. Facility or school-based programs are most effective at increasing coverage, but at the same time, with low levels of knowledge, there could be backlash when introducing a school-based vaccination program directly, because only 18% of the population have correct information. So at a later stage, once the knowledge increases, this would be the best approach to deliver the vaccination. Best practices also include implementing a gender-neutral vaccine. If we're starting now, why use data from before 15 years? The current recommendation is for gender-neutral vaccination, and this is what we are going for. Early initiation of HPV vaccination at ages 9 or 10 years results in larger rates of reduction in HPV-related cancers, and we're focusing on early vaccination. And we'd involve all relevant stakeholders, such as healthcare providers and policymakers. And we focused on strong healthcare worker recommendations. And if you want to take one thing from the slide, it's just to advocate the HPV vaccine for your patients, because your voice is what will make the impact in terms of an individual receiving the vaccine. Thank you very much. Happy to take questions.
Thank you, Doctor, for the amazing lecture. We have a lot of questions. One of the questions asking about the age above 45. Does they will take the vaccine in next step?
So the vaccine is currently registered for ages 9 to 45. This is based on effectiveness. After the age of 45, the effectiveness decreases. So in Kuwait, it's licensed and registered for those ages between 9 to 45. Saying that, other countries, so for example, the European Medicines Authority has no upper limit in terms of an individual over the age of 45 receiving the vaccine. In the States, they limit it to 45. In Kuwait, we went with the recommendation, the vaccination committee went with the recommendation of limiting it 9 to 45, mainly due to the data related to effectiveness. So 45 years is the upper limit for vaccination.
It's the vaccine safe for pregnant?
The vaccine is not given during pregnancy.
One question regarding if the patient active warts can take the vaccine?
Yes, and another thing is individuals who do have warts, they're at higher risk of other HPV-related strains, so they should receive the vaccination. They should be more likely to get the vaccine. And in addition, individuals with HPV-related cancers, even though they do have an HPV-related cancers, they should also be recommended the vaccine if they're less than the age of 45, because they're at high risk of other HPV-related cancers. Because as we know, the vaccine prevents against 9 different types of HPV. So even though you're exposed to one type of HPV, you could still be exposed to the other types of HPV. So because they already have genital warts, they're at high risk of exposure towards HPV, you should recommend the vaccine to them.
The vaccine in Kuwait is available for men also? The
vaccination is available for males and females, and you should recommend the vaccine for both. Focus on early vaccination. So from the age of 9, as soon as you have the opportunity to provide information related to HPV vaccination, you should take that opportunity to advise your patients to take it.
It will be included in the schedule for the vaccination table for children?
Currently, during phase 1, it's an optional vaccine. So it's only individuals who want to receive it that will go to the clinics. So the main goal of the first phase is just to increase awareness. It will be included in the vaccination series in the future once the level of knowledge and awareness is increased.
Last question. Yeah. It's free?
It's free of charge
Yes.
for Kuwaitis, and it's at cost for non-Kuwaitis.
Okay, thank you,
Thank you.
Doctor. Welcome, Dr. Adina. For award, Dr. Hamad.
Thank you, Dr. Hamad, for the informative lecture. I would like now to introduce Dr. Wasil Al-Atsani. He is a specialist in infectious disease, internal medicine, and geriatric medicine, Mubarak Al-Kabir Hospital and Infectious Disease. Welcome, Doctor. The mic is yours.
Thank you. Thank you. Thank you for inviting me. Actually, I left Kuwait about 2 years ago to the States, where I've been practicing in the last 2 years. I feel at home in so many ways because the patients I see are mostly HIV patients, and I tend to do their primary care. So in the half hour I spend with them, 5 minutes is on HIV, and the rest is on primary care. In my heart of heart, I'm an ID doctor, but I still go to the basics as a family practice trained physician. So with this in mind, one more point I wanted to make, listening to the HPV vaccine lecture, it's ironic that in the stands, there's a lot of pharmaceutical reps, but none is representing any vaccination, which is the most essential part that we do from day in and day out. I want to talk about emerging infection and what does the primary provider needs to know. From my standpoint, the top 10 infectious disease challenges that we face these days is climate change, vaccine hesitancy, inequity and disparity between the haves and the have-nots, aging population and the infectious disease implication in the elderly, healthcare shortages, burnout, and talent drain, and I certainly can speak to that from a personal level, artificial intelligence, metagenomics, globalization, antimicrobial shortage, and clinical implication, resistance, and outbreak preparedness. And my focus today is on the last 3 points. With respect to the antimicrobial shortages and clinical implications, no more this becomes to the surface with the epidemic of sexually transmitted infections in the last 2 years. We all know that syphilis, gonorrhea, chlamydia is on the rise, and Kuwait is it's not safe from that. This culminates also with antibiotic shortages, specifically penicillin. I'm sure you all know that amoxicillin is in short supply, and penicillin G, which is the main drug to treat syphilis, is also in short supply. So what's the alternative here? The CDC recommends that doxycycline is the treatment if you don't have penicillin G in your clinic. Early syphilis, anything less than 1 year, so it could be early secondary or early latent, doxycycline 100 milligram twice a day for 14 days. Late syphilis, more than 1 year, the diagnosis is made, or if it's unknown duration, then doxycycline 100 milligram twice a day for 28 days. What's important here, and what I want to emphasize, Do not let the patient go away thinking that you treated him and they're fine, or treated her and she's fine. It's important that you bring them back to your office and recheck their titer, their VDRL or RPR titer, and document a fourfold decrease in their titer to ensure that treatment was successful. For those of you who are interested in this, I keep this on my terminal at work. This is the National STD curriculum from the University of Washington. It's free. It gives you references from monkeypox to syphilis to gonorrhea to chlamydia to herpes, all STI. It's a great resource, and I would highly recommend it. Again, free of charge. Let me shift to antibiotic resistance and talk on a micro level. What can the primary care provider do to at least offset this resistance that we see from day in and day out in our practice? I want to highlight to you the Agency for Healthcare Research and Quality. And often for my residents, the house staff, be it family medicine or internal medicine residents, I often refer to this. These are some points, and for the house staff here, the junior physicians here, that you might want to take with you is, how do you treat UTI? How do you treat cellulitis? How do you treat respiratory infection? Again, these are tools for you, and it's a checklist, basically. Recognize for UTI, they're going to have about 14%, one in seven patients where you give antibiotics without culture is going to be discordant, meaning you're going to give the antibiotics and the culture is going to show a different bacteria. So that's the discordance here. Cellulitis, skin and soft tissue infection, and lower respiratory tract infection. Let me just say one word about this. The GOLD criteria in 2023, this is the global initiative on COPD, no longer it looks at COPD as one entity. Now we have mild COPD exacerbation, moderate COPD exacerbation, and severe COPD exacerbation. So not every COPD exacerbation is created equal. And yes, we continue to give antibiotics for these patients, but keep that in mind as well. We shift a little bit to TB and tuberculosis. The Global Tuberculosis Report in 2023 just got published. And these 8 countries represent 2/3 of the world TB cases in 2022. I have to be cautious and remind myself over and over again that not every citizen from India has TB. Not every citizen from the Philippines has TB. I think we need to be cautious about stigmatizing individuals. Having said that, again, these are should be kept in the back of your mind as high-risk epidemiological locations where people might be exposed to TB. TB continues to be, in 2019, this is certainly pre-COVID, and this is WHO data, as top 15 killer in the world. In Kuwait, certainly this is old, 25 years ago or so, TB doesn't register. Ischemic heart disease or cardiovascular disease remains number 1, road accident number 2, and I suspect that ratio has not changed even in 2023. And I'd like to think that congenital anomalies and childhood diseases are no longer top 10 killer in Kuwait. In 2022, the Kuwaiti government, Ministry of Health, reported 520 cases of tuberculosis to the WHO. Of those, 16 mortality in a population of 4.3 million, and which represented 45% decrease from the 5 years earlier, which is great. I mean, I think that speaks to a public health system that's working, that's catching people early in the disease process and treating them or screening more effectively. Interestingly, that MDR and XDR, these are multi-drug resistant or pan-drug resistant, extensively drug resistant, I should say, are very minute. And that has implication for latent TB, which I will not go through right now. Treatment success is 100%, which is great. So a word on latent TB, because I think that is something that the primary care, I totally believe that should be involved in and address. Mycobacterial tuberculosis, as you know, is airborne. 30% of those exposed, only 30% get infected. 90% of those go on to develop latent TB, and 10% develop active TB. The United States Preventative Task Force this May said we need to be screening for TB, and we screen for specific population for these TB. They did not define the interval, but they said screen. And the benefit of screening is not for the sake of screening, but for the sake of screening and treatment. So who are those population? It's household or close contact of active TB cases, birthplace of endemic country with TB, patients in prison or homeless population, or immunosuppression. Anyone on prednisone or equivalent of 15 milligram or more than 1 month ought to be screened for latent TB. The American College of Rheumatology in 2022, their guidelines, they push up the prednisone dose to 20 milligram, and that's a debatable point. We have 2 screening tests, the old TST, which I never use in my practice, and the interferon gamma release assay, T-spot and quantiferon, which are also available at Kuwait. What I want to say is, with respect to the interferon release assay gamma, BCG vaccine, which most of Kuwaitis born in this country have had, does not interfere with the IDRA test. So you can go ahead and give that, and if it's positive, it certainly is positive. Treatment regimen, no longer we do isoniazid for 6 to 9 months. That is too toxic of a treatment regimen. We have 3 regimen that is approved by the CDC, 3HP, 4R, and 3HR. And certainly you can have access to my slide. They're straightforward. And I really think that there is no reason the primary care provider should not be treating latent TB. These regimens have proven to be safe. There are multiple meta-analysis studies. Hepatotoxicity is very, very low. And the way I approach it with my patients, I bring the patient, sit him by next to me, and we look at the computer, and I put up the online TST interpreter. So in this case, I have a patient who has a positive IDRA. He is 50 years old. He's a Kuwaiti citizen. He's been vaccinated for BCG. He had casual contact with someone who had TB. He's diabetic, and he's a smoker. And I push submit, and it gives me this brief. And I go over this with the patient. I tell them, hey, listen, this is your characteristics. If I treat you with INH, which is the most toxic medication, your annual risk for developing TB is 0.52%. Your cumulative risk for a lifetime is 15%, which is high. And if I treat you with INH, again, the most toxic, then you have 2.3% chance of drug-induced hepatitis and 0.6% chance of being hospitalized for hepatitis. And I document this in the chart. Literally, I take this, cut and paste, and put it in the chart, discussed with the patient. The question is, what if, so we know about latent TB. You're positive, your chest X-ray is negative, and you're positive IDRA. We know about active TB. You're coughing, you're losing weight, you have night sweats, you have hemoptysis, you have chest X-ray with a big granuloma in your left upper cavity. What about these patients who come in from a high endemic country? You get a chest X-ray, there is a big granuloma in their left upper cavity. Yet you do a PPD or you do an IDRA and it's negative. You get a sputum culture, you put it for 6 weeks looking for MTB, mycobacterial tuberculosis, and it's negative. What do you do with these patients? And how do you approach these patients? And this is probably an ID consult or a pulmonology consult because it's not easy. Shifting back to the last point that I want to make about emerging infections and outbreak, this is not going to go away, unfortunately. Just in 2023, as we're closing the year, look at the infections that we've had. We've done with arboviruses. Arboviruses is dengue, viruses that you get from mosquito bites, West Nile virus. We've dealt with avian flu. We've dealt with botulism. Candida auris is prevalent in Kuwaiti ICU, unfortunately. Cholera, COVID, still around. Fungal meningitis outbreak in Mexico. Monkeypox, and so forth. And what I want to end with, that infections and special pathogens are not going to go away. The last 2, 3, 4 years of the COVID years have been really challenging and trying. And I hope that we have learned some lessons that we can take with us, that change does not come from the top, but rather change comes from the bottom up. I think we proved to ourselves that working on a micro level in groups, we've overcome a lot of challenges, particularly during the COVID years. I think practicing resiliency and keeping our antenna up for the next challenge is the best weapon that we can do. Thank you very much, and I want to thank the organizing committee for inviting me today.
Thank you very much, Dr. Wasil, for the very useful information that you gave us. We have a couple of questions here regarding the antimicrobial resistance. Do we have any system here in Kuwait to report these antimicrobial resistance?
As far as I know, no, unfortunately. Just let me just say this. Reading an article the other day, again, I want to emphasize 14% of the patients that you see in your clinic, if you treat them for UTI, you're going to have a mismatch. So keep that in mind. But no, we don't have data that report this. We have hospital data on the individual level, but I don't think we have a national data on that.
Do you think the availability of the antibiotic over the counter contributed to the resistance?
Oh yeah, I mean, certainly, huge. It's a huge problem. It's a huge problem, and I think we're at a stage right now where the cat is out of the box, meaning we have so much multi-drug resistant pathogens. ESBL is everywhere. When you get a urine culture, you have to think that you're treating an ESBL, extended spectrum bacteria, beta-lactamase resistant. So from that perspective, what I would advocate and push for, I think the diagnostic stewardship. These days, I mean, in my clinic, I have someone comes in with a cough, with a runny nose. I send them to the microlab, and within 2 minutes, I have a result of a PCR that tells me whether this patient has COVID or whether this patient has mycoplasma pneumonia. I think diagnostic stewardship, with particularly PCR technology and metagenomics, will play a huge role if we can implement them at least at the primary care level. But I mean, hopefully one day.
Thank you very much, Dr. Wasil. I would like to invite Dr. Adina to reward Dr. Wasil a trophy of appreciation.
you, Dr. Wasil, and thank you, Dr. Hamad. Our next valuable speaker is Dr. Fatma Al-Hadhoud. Dr. Fatma is a consultant obstetric and gynecology and minimally invasive gynecologic surgeon. She works in the Department of Maternity in Jabra Hospital. She is a Kuwaiti board certified, and she had her clinical fellowship in Miami in minimally invasive gynecological surgery, University of Ottawa. She is the program director of postgraduate Kuwait residency program in obstetric and gynecology. And a soft reminder for all of you, please, when you write a question, don't forget to choose Dr. Fatma Al-Hadhoud's name. And Dr. Fatma, you are welcome.
Okay, thank you. Thank you for the invitation. Good morning, everyone. I'm here today to discuss about the hormonal replacement therapy, what's the right for menopausal patient. First, my objective for this talk to talk about what's menopause and the symptoms of menopause, what's the use of menopausal hormonal therapy, and how to follow up the patient and monitor after starting this kind of treatment. So what's menopause? Normal women have a menopause at the mean age of 51 years old. When becoming menopause, usually between the range of 45 to 55 years. The natural menopause is permanent cessation of menstruation resulting from the loss of ovarian follicle activity. So menopause is confirmed when there is a 12 consecutive months of amenorrhea and the absence of other pathological or physiological causes. So in the perimenopausal period, estrogen and progesterone start to decline. According to the normal cycle of each woman, the estrogen and progesterone levels start to decline after the age of 40, reaching to the least or the minimal levels in the circulation by the age of, or the late of 40, early 50. So symptoms experienced during menopause and perimenopause are associated with these changes in the hormone in this time of period. So it's a major life event, affect all women. Up to 80% experience physical and emotional symptoms at this time. I know I'm mentioning this because nobody in the practice, or I notice giving the attention for menopausal symptoms and consider this as a normal or changes in the woman life without giving the care or guide the woman what to do and what to prescribe. So symptoms can last from a few months and can also extend to several years. So women will be affected by these symptoms and suffer and affecting their quality of life for a couple of years. So what are these symptoms? These symptoms include hot flushes, sweat, tiredness and sleep disturbance that affect their quality of life. They will have some joint and muscle ache, heart palpitation, mood swing, anxiety, depression, lack of concentrations, and some local disturbance of low estrogen in the circulation, like vaginal dryness, vulval irritations, and discomfort. And even during their sexual life, they will have some difficulty or decrease in the interest or desire. So menopausal hormonal therapy is the new term used to replace the hormonal replacement therapy. So it's a broad term used to describe the unopposed prescription or use of estrogen. We will add progesterone if the women have her uterus to protect her from endometrial hyperplasia. But if she's not having her uterus for any surgical reason, we can just prescribe the estrogen. So in the past, as I mentioned, hormonal replacement therapy now being used and changed the term of menopausal hormonal therapy, which is more comfortable to use than the old term. So what's the primary goal for the menopausal hormonal therapy? Is to relieve the symptoms. 80% of the menopausal women will suffer from hot flushes, sleep disturbance that will affect their quality of life, some genitourinary syndrome that will cause some irritation, vulval dryness, and some frequency and discomfort in the genital area. So the most symptomatic or like bothering symptoms is the hot flushes. So I just want to highlight the Women Health Initiative trials that been published in 2002 that changed the whole practice for prescribing the menopausal hormonal therapy for postmenopausal women. Because of this trial, it was supposed to be run for 8.5 years and stopped after 5 years because of the outcome from the treatment group comparing to the placebo, because of the adverse outcome of breast cancer, then being stopped after 5 years. This trial being studies according about 27,000 postmenopausal women divided into treating group and placebo group, and being stopped because of the adverse outcome. So the practice all been changed after this publication in 2002, and there will be there was a changes in the practice for prescribing menopausal hormonal therapy for menopausal women. So these changes in the practice causing decline in the prescription for this hormone and not giving the attention for menopausal women's symptoms because of the fear of having the adverse outcome from the hormonal therapy. And also we noticed that there was a little attention and teaching and education for the medical student, even resident and junior doctors in the different fields like internal medicine, obstetric and gynecology, even the family medicine, about this chapter of treatment and giving the attention for women at this area. So we hope that the teaching and education being more change and giving the attention for this a group of patients and try to practice hormonal replacement therapy within a reasonable, saving prescription for this kind of patient. So how we know is if it's my patient is a candidate for having menopausal hormonal therapy. There's a factor should be considered before prescribing these kind of hormones or a treatment. The patient age, when it was menopause, is the menopause isn't within a couple of years. If she's having the symptoms more than 10 years, so there is no use of having or prescribe hormonal therapy. If there's severe symptoms that affecting her quality of life, then we have to consider this kind of treatment. And we have to calculate, and I want to just highlight this point, that the risk of cardiovascular disease and breast cancer. So before prescribing this kind of hormone, we have to calculate the risk for this patient. There is different tools to calculate this risk according to international guidelines. So the treatment is individualized. So each patient has different approach. So we have to weigh the benefits according to the risk. For most of the symptomatic postmenopausal women, if she's under the age of 60, she's on the safe criteria to start and not beyond 10 years of menopause. So this is the age group we have to consider. While the Women Health Initiative trial clearly demonstrate the adverse because of the risk of breast cancer and cardiovascular disease and stroke, The older postmenopausal woman beyond the age of 60 is considered not suits for this kind of treatment. So at this age of group, treatment should be avoided. When counseling the women with menopausal hormonal therapy, the clinician should provide an estimate, as we mentioned, the risk and the benefits of 5 years of treatment duration for according to the age between 50 and 59. Women should be reassured that the absolute risk and complication for healthy young postmenopausal women taking the hormonal therapy for 5 years is low. Why 5 years? According to the trials and studies, 5 years seemed reasonable to treat most of the postmenopausal symptoms. Some of the patient we can extend according, and as we mentioned, we have to individualize. So usually the treatment is 5 years duration. So how we calculate the risk? It's important to know, according to the applicable tools, we are using these tools to calculate the risk according to the Endocrine Society approach that guidelines published in 2015, suggesting that calculating cardiovascular and breast cancer should be initiating. So we use the cardiovascular calculator estimating risk for 10 years interval, and I don't know what's wrong with the text, but according to this calculator, the estimate, if it is less than low group, if it's in the low group, it's no harm to start the hormonal replacement therapy. And if it is in the moderate or high group, we suggest to use the non-hormonal therapy for treating these kind of symptoms. So for evaluating the cardiovascular risk, we said the 10 years interval of estimating risk. If it is low, less than 5%, no harm to use the hormonal therapy. If it's moderate, we have to use it with caution, and we prefer the topical or local use of this kind of hormone. If it is high group, should be avoided. For the breast cancer calculating risk, we use the International Breast Intervention Study criteria for cut off the risk of having breast cancer within 5 years. If the patient in the low group, it is okay and safe to use the menopausal hormonal therapy. If it's in intermediate group, we prefer to avoid, and absolutely if it's in high group, we should avoid it. So the tools available for calculating the cardiovascular risk, this has been taken from American Cardiac Society and American Heart Association, putting the patient age, gender, the age group, the total cholesterol according to the patient investigation, and it's by clicking the reset, we'll get an estimate risk of cardiovascular disease within 10 years. What about the breast cancer? We used an online assessment tools or calculator, which is the Gale model, to estimate the risk for invasive breast cancer over the 5 years up to age of 90. These tools are useful for calculating the risk according to the woman's personal history, family history, if she has a previous breast cancer, if he has first-degree relative of breast cancer, and the kind of, or the type of breast cancer. So we should know that the contraindication for using the hormone, if she's having a history of breast cancer, the patient currently have a previous history, she has congenital, coronary heart disease diagnosis, previous venous thromboembolic events, active liver disease, there is unexplained vaginal bleeding, high risk of endometrial cancer if she's having the gene. In some groups or families, there is a gene running causing a high risk of endometrial cancer, like the Lynch gene, or she's having transient ischemic attack or stroke history. So these are the contraindication. So I'll talk about the estrogen options for treating menopausal symptoms. So estrogen coming in all types oral preparations. It's coming as oral, transdermal, topical, lotion, vaginal ring, or subcutaneous implant. Unfortunately, what we have here, it's a limited preparations, and we have just one kind of oral estrogen and some local or like lotion treatment. The choice of a preparation is based on the patient preference, the drug availability, as we mentioned, and the cost. And if, according also to the patient symptoms, if she's having mainly the genital or vaginal or genitourinary symptoms, we go for local estrogen preparations like the vaginal tablet or lotion. And if she's having symptomatic hot flushes, we'll go for the oral preparation. So our availability is limited. We prefer the 17-beta estradiol preparation, which is bioidentical for the main estrogen secreted by the ovary, but it's not easy to get this preparations. It's available abroad, but here what we have is the estradiol valproate. So what's the dose? We are giving 1 milligram standard dose for the patient mainly complaining of hot flushes. It's taking on a daily basis, and it's will be affected and adequate for the symptoms relief for the majority of women. The exception is the younger woman who's having severe symptoms of having hot flushes or other symptoms of menopause, or undergone surgical oophorectomy for any medical reason. So the dose can be increased to 2 milligram daily to be subsequently affected in this kind of group. And then when the symptoms are being relieved, we can be tapered down to 1 milligram. So the estrogen option we have to treat the menopausal symptoms like hot flushes, we will take the systematic preparation. If we have local complaint, we use the topical treatment, like mentioned, vaginal tablet or cream. Progesterone only added if the patient has her own uterus. It's only to protect the uterus or the lining of the womb from getting endometrial hyperplasia, then later cancer. So only the adding of progesterone is for a protective value of the woman having her uterus. We can use 2 preparations, either continuous progesterone or cyclic preparations, like similar to the physiological hormones in the woman cycle. So we mentioned that giving the dose in 2 preparations, the amount or the recommended dose is 200 milligram per day, either giving in cyclic, the late 14 days of the month, or giving in continuous regimen. I mentioned the progylitone because it's one of the options available here in Kuwait. It's 11 white tablet of estrogen valproate and brown tablets that contains estrogen and progesterone. This is helpful to relieve the patient's symptoms. Again, if the patient have her uterus, we'll use the whole packet. If the patient has no uterus, we will use only the white tablet. So no use of having the brown tablet, so only the white to replace her estrogen. The other option we have here is the Primarine cream, which is a topical cream applied vaginally, or the Intrarosa, which is dihydroepiandrosterone, which is a precursor of steroid that been converted vaginally to estrogen and testosterone. It's helpful also for vulvovaginal atrophy and genitourinary syndrome. Tibolone, also available here in Kuwait. It's a synthetic steroid, helpful to minimize the hot flushes in postmenopausal women. It's metabolite to estrogen and androgen and progesterone. It's a 2.5 milligram preparation tablets then being taken every day. It's helpful for minimizing the symptoms, and we can be used for a period of like 5 years. We have to be cautious when we are giving the Tibolone. We mentioned it's like a synthetic steroid, but also we have to categorize the patients and individualize the treatment, and to look for the risk of having or using Tibolone in this kind of patient. So there is a vascular and endometrial and breast effects of Tibolone when we are used. So if the patient having a history of stroke or coronary heart disease, these two groups, according to the publications and trials, should be limited, with the common trial being published, the left trial. So Tibolone should be avoided in this group. If the patient have vaginal bleeding or endometrial hyperplasia, also Tibolone should be avoided and prescribed in this kind of group. If the patient should be having like a breast cancer risk, should be avoided. But if the patient has no breast cancer, so we can prescribe this medication. So patient with current or previous history of breast cancer, Tibolone should be avoided. If there is no risk of breast cancer, it's safe to be used for a couple of years. So how we follow up and monitor patient with menopausal hormonal therapy? We should adjust or adjust the doses according to the patient symptoms in the first 3 to 4 weeks of the therapy. If the patient is having severe symptoms and the 1 milligram estrogen is not enough, we can increase the dose to 2 milligram, and according to the patient relief symptoms, then again we'll taper down the dose to 1 milligram. If the patient has persist severe symptoms, we can start it directly with higher dose instead of having lower dose and increase. So according to the patient, we could start either with the higher dose or starting with a small dose and increase.
Sorry for interruption, Dr. Fatma, you have only 1 minute.
Okay. For follow-up and monitoring, we try our first tapering between 3 and 5 years, depends on the patient age. If she's younger, we can start after the 5 years. If she's old, between or late 50, we start to taper after 3 years. For women who started menopausal hormonal therapy at late 40 with the severe symptoms, we can wait at least 5 years, as we mentioned, before tapering down. We should reassure women with absolute risk of complication that is minimal for healthy young menopausal women. Endometrial monitoring, we should do regular endometrial monitoring for patient on hormonal replacement therapy, and monitoring the thickness or whether she's having any abnormal bleeding. We can do that by sampling or doing transvaginal ultrasound. Also, we have to monitor by doing a mammogram yearly, routinely with patient with menopausal hormonal therapy, and stop according to the findings of the mammogram. So the standard recommendation, we said 5 years. We can extend if the patient is young, healthy, and having no risk of having any kind of coronary heart disease or breast cancer. The timing of stopping is 5 years. We can stop early if the patient has any symptoms or having a recalculated risk of having a coronary heart disease, which becoming from low to moderate or high risk group, or she have any breast lesion, or she's been changes from low risk group to high risk group. So according, I'll just mention now the non-hormonal options that have been available in the market. It's a natural supplement. They don't have any hormone. It can alleviate and treat some hot flushes in postmenopausal group if you are worried to start the hormonal therapy. Just quickly to mention about the risk of cancer, it's increased risk of breast cancer. Also, there is no significant risk increase with the ovarian cancer. It's increased the risk of endometrial cancer without monitoring. And it's reduced the colorectal cancer in patients at this group. So hormonal therapy with the cancer, it can increase some kind of cancer, no effect on some organs, and may reduce in the risk of colon cancer. Thank you, and sorry for the long talk, and thank you for again for the invitation on this conference. We're happy to be part of this.
Yes, thank you so much, Dr. Fatma, for your talk. And I believe that you answered some of the questions that was sent, which is the duration. Okay, you said it's 5 years.
Yes.
Okay, and one of the questions is, what do you think of other drugs for the perimenopause, the menopausal, like antidepressant and the ashwagandha?
Yes, we can use the antidepressant with the hormonal therapy for patient complaining of anxiety or depression. It's helpful at this patient group. We recommend to start both or one and see how is the patient respond, and then we can taper the hormonal therapy and continue on antidepressant, especially the selective serotonin reuptake inhibitor, and then taper it according to the patient's symptoms.
Yes, and do you advise the primary healthcare physician to prescribe a hormone replacement therapy and to monitor and follow the patients?
If they got enough education and teaching, and they are willing to prescribe and happy to, there is no harm to start and keep monitoring and follow up the patient according to the patient.
Yes, and the last question is, any risk for systemic absorption of topical hormone for highly risk patient?
Theoretically, no, but always we are worried and caution with high risk group when we're prescribing local or topical hormone.
Thank you, Dr. Fatma. And please, I'm going to invite Dr. Dalia Sane to give you an appreciation token.
I would like to thank our speakers for their informative lectures in session 4, and we'd like to thank our moderators for session 4, Dr. Anwar Bouhamra, Dr. Ibtihal Mhamid, دكتورة أنوار الصايغ. I'd like to welcome the moderators of session 5 onto the stage, دكتورة فاي العجيل, دكتورة فاطمة بشهري, and دكتورة ليال منوفي.